Hey everybody, welcome to my lecture over physical therapy data collection. So this content area shows up everywhere on the exam because it represents the everyday tests and measures that you'll perform as a PTA. So we're talking things like vital signs, goniometry, manual muscle testing, sensation, reflexes, wound assessments, edema assessments, outcome measures, and so that encompasses a whole lot of things. So today we're going to talk about the different ways that we can look at data collection through the systems. We'll walk system by system and focus on 3 questions for each test. What am I measuring? What does it mean? And what is my next safest step as a PTA? As we go through this, think beyond memorizing the numbers because while that is going to be helpful to know some of those important norms, the more important thing is to focus on patterns. We want to say, does this data say that it's safe to continue? Do we need to modify treatment? Or do we have to stop and report this? Data collection matters for 2 big reasons. We have patient safety and also, obviously, exam success. Clinically, the PT is responsible for examination and evaluation, but you know that you as the PTA are constantly gathering objective information that tells you whether the patient is tolerating treatment or they're getting worse and we need to do something to revise our plan. So on the exam, this category makes up a big portion of the questions, and strong data collection skills can help you spot red flags when you're in the clinic, so that way we translate being a safe clinician and passing your boards to being a safe clinician and identifying those concerning factors in the clinic. We want to think about moving through each of our systems. We've got 23 to 34 scored questions on this, and so that's going to cover a lot of systems, and I think the next slide I'm going to break that down a little bit more. But you want to ask yourself, as you're going through the questions, if you saw something represented by this finding in the clinic, what are you actually going to do? And is that action within your scope? And this is one of those times where you have to think about erring on the side of caution for safety. We don't want to be overly cautious. That's not going to be the safest option is always right. But we need to think about what we do clinically in those gray areas is not the same as the black and white that we're looking for this exam. So overall, the approximate exam blueprint for data collection, we've got cardiopulm that contributes 5 to 8 questions. Musculoskeletal and neuromuscular are the heaviest hitters, so 9 to 12 and 8 to 10 questions for each of those. And then lymphatic usually only contributes a small amount, and you've got 1 to 2 for integumentary too. So this gives you a breakdown to guide your studying, not necessarily to say that you can blow off integumentary or lymphatic, but just give you an idea of how to guide through it. And you want to make sure that you can answer what's normal, what's abnormal, and what you would do next for each system. Make sure we just spend extra time with the big 3. So when you see a data collection question on the exam, you want to follow a simple 4-step process. Step 1 will identify what type of data we're being given. Is it a vital sign, a goni measurement, a wound description, a gait deviation, or a score on an outcome measure, or any other one of our options. Step 2 will compare that data to normal or expected findings, and we're going to determine whether the information they're giving us is clearly normal, clearly abnormal, or if it's borderline. Step 3 will decide on the action as a PTA. So is it safe to continue? Should we modify or stop the activity? Do you need to notify the PT or the medical team? And then step 4, we want to stay within the PTA scope. So you're going to collect data. You can modify interventions within the established plan of care, and you can report significant findings, but we're not using any of the data that we collect to diagnose or independently create a brand new plan of care. And so be careful of answer choices that point you in doing something outside of the scope. When we get to some of the quiz questions that I've got in here, we can point some of these things out so that way you can try thinking about it under pressure. For cardiopulmonary data collection, you want to think about a sequence that starts with vital signs at rest and then vital signs with activity. Then we'll look at breathing pattern and chest wall movement, and then symptoms present with exercise, and then finally peripheral circulation. So you're checking heart rate, blood pressure, respiratory rate, oxygen saturation, and sometimes temperature in the clinical field or scope that we're looking at here. And you're watching how all of these things change with exercise and or position changes. So don't forget our position changes too. In pulmonary patients especially, we need to consider the cough effectiveness, so we'll also look at things like sputum characteristics and chest wall excursion. we'll ask, again, when we reflect on these questions, what does normal look like? What does a slightly abnormal but acceptable response look like? And what would clearly unsafe look like? On the exam, they may not say the words, "this is unsafe," because that would be a dead giveaway, but they'll give you numbers and descriptions that they want you to recognize the patterns that require you to either slow down, stop, or call for help. So going over some of those anchor numbers for heart rate and blood pressure and our other vital signs we'll talk about here. So heart rate, our normal is roughly 60 to 100 beats per minute. Anything below 60 is going to be considered bradycardia. Anything above 100 is going to be considered tachycardia. For blood pressure, we want to think of 120 over 80 as our typical normal. Hypertension is usually 140 over 90 and up, and hypotension is closer to 90 over 60. Especially if the patient is symptomatic. I know that there might be some discrepancy on those borderline blood pressures between your different practice exam resources. Don't get caught up on um, the borderline ones. Know your black and whites for the actual exam. Orthostatic hypotension is defined as a significant drop in blood pressure, and so we want to see a drop, usually at least 20 millimeters of mercury, of our systolic pressure with a change from supine to sitting or sitting to standing, so any of our positional changes. And that's often accompanied by dizziness or lightheadedness, because those are the symptoms the patient will experience with orthostatic hypotension. If you see a clear orthostatic drop and symptoms placed in a question stem, your safest response is going to be to return the patient to a more supported position, monitor them, and then notify the PT or nursing as appropriate. We never want to just push on with the activity if we're seeing signs of orthostatic hypotension, but we also don't need to just stop treatment altogether. We want to monitor and update the PT as needed. When you read exam questions, circle or mentally highlight things like our vital signs for heart rate, blood pressure, and ask if they're normal and expected increase with the activity that the patient's performing or described performing. Is it too high, too low, or dropping when it shouldn't be? And use those kind of thresholds to make your determination to guide you towards the right answer. For respiratory rate, a normal resting value in adults is 12 to 20 breaths per minute, so you should see smooth, relatively effortless breathing at rest. Rapid, shallow, or labored breathing suggests increased work of breathing, and so that's going to indicate that the patient is struggling. Pulse ox, or our SpO2, should generally sit in the 95 to 100% range on room air. Values below 90%, especially with symptoms like dyspnea, shortness of breath, dizziness, confusion, those are going to be our red flags to say, oh, we need to do something to make sure that the patient can take some deep breaths. So we'll, pause treatment, encourage pursed lip breathing, anything to help bring that O2 back up. Capillary refill can be checked at the nail bed, and anything less than 2 seconds is typically considered normal. Longer refill times can signal decreased peripheral perfusion, so we don't have enough blood flow to the extremity. And if an exam stem is describing something about decreased capillary refill, then we probably want to connect that to our potentially peripheral pulses, which we'll talk about as well. Also, and if an exam stem is describing something about SpO2 dropping below 90% with activity or associated symptoms, that, again, we talked about should trigger your decision to stop or modify. And again, our goal is to do something that's going to help the patient recover in that moment. We don't want to push through activity, but we also don't necessarily need to terminate treatment altogether. Our focus is to help patient recover. Moving on to auscultation, we need to be able to recognize obvious normal and abnormal patterns. So our normal heart sounds are going to be our S1 and S2. That's our normal lub-dub. Our normal breath sounds should be clear and equal bilaterally. So if we see something documented outside of those things for heart sounds or breath sounds, then that's an abnormal response, and we want to be able to identify that. Abnormal lung sounds that we should be able to recognize in the descriptions are going to be things like wheezes, which suggest airway narrowing or that bronchospasm associated with asthma. Crackles, which suggest fluid in the lungs, such as in heart failure or pneumonia. And absent breath sounds on one side is going to mean that airflow is not getting there, and so that's going to indicate something like a pneumothorax or collapsed lung. During exercise, a normal response includes gradual increase in heart rate and systolic blood pressure, a moderate increase in respiratory rate. Going back to blood pressure real quick, we should see a steady diastolic blood pressure. We shouldn't have very much, if any, increase to our diastolic blood pressure. And then we should have a stable or, SpO2. So we might drop a little bit to that 95%, but overall our oxygen saturation should stay pretty steady. Abnormal responses are going to include a drop in systolic blood pressure with increased workload, an increase in diastolic pressure greater than 10 millimeters of mercury, new chest pain, marked dizziness, or significant desaturation. Sometimes you might also see things like the dyspnea or angina scales that are going to be used. Remember on that higher ratings on those combined with abnormal vitals are going to stop the decision or support the decision to stop or slow down your activity. Anything above a 2 or 3 on those are going to be definite, hey, that's our threshold to pause. Objective measures we might see are going to be things like our endurance tests, like the 6-minute walk test, which remember gives you a functional picture of the patient's cardiopulmonary capacity. For the 6-minute walk, we want to know the baseline vitals, the distance the patient was able to walk, and the symptoms that they experienced during the test, and how those values change over time with training. So then we're able to track the patient's progress over time by comparing measurements at the beginning of episode of care, then a reassessment, then at discharge. Other submaximal tests are going to include things like a 2-minute step test, and that serves a similar purpose, like to measure how far a patient can do. We'll also see things like use of the Borg rating of perceived exertion, so our RPE. The RPE of around 13 corresponds to somewhat hard, and so remember that scale goes from 6 to 20. 13 correlates with somewhat hard, and that's our threshold to cut off for some of our cardiac patients, but we want to be paying attention to utilizing RPE scale when our patient is on beta blockers and heart rate is not a reliable response. On exam questions, look for patterns over time. So an increase in distance with stable or improved vital signs. This response suggests progress. Decreasing distance, worsening symptoms, or increasingly abnormal vitals is going to suggest declining endurance or poor tolerance, and that's going to influence how you progress or regress your interventions. For peripheral circulation, first think pulses, skin, and edema. So our dorsal pulses, like our dorsalis pedis and posterior tibial, are typically graded from a 0 to 3. So 0 is absent, 1 plus is diminished, 2 plus is normal, and 3 plus is bounding. Diminished or absent distal pulses, especially if they are in place with like cool, pale, blue cyanotic skin, we want to know that those things are going to point towards arterial insufficiency, and that raises the concern for blood flow. Edema can be pitting or non-pitting, and so understanding the difference between those and then how to grade our pitting edema is going to be important. Pitting edema is graded from 1 plus to 4 plus based on how deep the pit is and how long it takes to rebound. From a cardiopulmonary standpoint, bilateral leg edema is going to be what we associate with heart failure, and so if they're giving us measurements of bilateral leg edema, that is something we want to pick up on as data collection that points us towards heart failure or venous issues. Trophic changes such as shiny skin, hair loss, or cool temperature is going to suggest poor arterial blood flow. And so if a question STEM describes those specific findings, we want to think about protecting the limb, avoiding excessive compression in severe arterial disease because that's going to restrict blood flow more. We want to elevate when there's venous insufficiency, but we want to leave them in more dependent positions with arterial insufficiency so that way we can promote blood flow to the area. And then we want to involve the PT to progress the patient or for medical referral when we see abnormal responses in those extremities. So we'll do a quick knowledge check here. During gait training, a patient's SpO2 drops from 96% at rest to 88%. The patient reports mild shortness of breath but denies chest pain. What is the PTA's best immediate action? A. Continue gait training and recheck SpO2 in 5 minutes. B. Slow the walking speed but continue activity. C. Stop the activity, have the patient sit, cue deep breathing, and monitor. D. Call emergency medical services immediately. Pause now to continue reading and ponder before we go to the question or the answer. So our correct answer here is C, and that's going to be the one that tells us to stop the activity, seat the patient down, cue them on the deep or pursed lip breathing, and monitor their SpO2 because drop to 88% is an abnormal desaturation that we want to make sure that we identify and adjust our response to exercise. The options that tell us to just continue activity unchanged aren't safe in this scenario because, again, that SpO2 dropping below 90% says, hey, we got to do something here. But they're not having chest pain, so jumping straight to EMS seems to be an excessive response. If they had had chest pain or something like a loss of consciousness or noticeable respiratory distress or something else to contribute to this where there wasn't the confidence in being able to help the patient recover their SpO2, we might call emergency medical services, but it's just an excessive response to this situation. So test taking a dip here below 90% is a red flag that they're going to look for, but they want to say, do you know enough to just say, hey, let's stop treatment, help the patient recover, not stop treatment altogether, but also not try to recover while we push through the exercise. Moving on to musculoskeletal. So musculoskeletal data is going to focus on a range of different things, like range of motion, strength, posture, gait, functional performance, muscle firing to a certain extent, but that's typically beyond the scope. And so, we'll try to stick to the things that are going to be most important. Your study guide also emphasizes the things like anthropometric measurements, for leg length, limb girth, pain assessments, and special tests. And those things are also important to review. I just don't want to make this lecture too long that you guys don't watch it. But the point with musculoskeletal data is that each measurement should tell you something practical. Like limited range of motion might explain difficulty with stairs because a patient isn't able to achieve enough hip flexion to get the appropriate foot clearance to go up the stairs. Strength deficit may also tell us something about difficulty with stairs because 3 out of 5 quad strength might show us that they can stand and they've got a risk of knee buckling in static stance, but they can't lift body weight up to elevate up to that next step. Leg length discrepancies might explain a pelvic tilt or different gait deviations. So if we have a longer leg on one side, we might see circumduction during the swing phase on that side because we're trying to clear the extremity. And so as we go through this section, try to think about the patients that you have really seen so that the data collection part can click. Remember, the safety concerns get into a little bit grayer area in the clinic than they do on the exam, and so you can't always apply those things. But if you can connect our data collection to things that you've actually seen, you're going to have better retention of it. And that'll help keep you from it being just about the numbers, but more the practical application and functional limitations that result. So range of motion is obviously measured with a goniometer, and it gives us objective joint angles. So it tells us the specific number of how far the joint can move. You don't have to know every single exact norm, but you want to know your typical values for your major joints. And so think about your shoulder motions, your hip motions, knee flexion, knee extension. If you don't know, then I'm not sure how we got this far. But thinking about the ones that you're going to see the most often, and at least knowing your norm values for those. In addition to normal degrees of motion, you also want to pay attention to what normal capsular patterns are and normal end feel is going to be. And so for the major joint movements, if you are given an end feel, is that normal or abnormal, and how would you respond? Because end feel is part of that data collection. And then understanding the capsular pattern for those major joints is also going to help you identify whether or not range of motion losses are consistent with a diagnosis that's related to the joint capsule, or if there is a range of motion deficit that is inconsistent with the joint capsule and there's some other referral that needs to happen or something of that nature. And so being able to pay attention to not only the joints and their major normative values for prime motions, but also the end feel associated with that motion and that joint's capsular pattern. Remember, our abnormal end feels are going to be empty, a springy block, spongy, boggy, or a hard stop where you don't expect to hit one, like a bony block. Um, our normal end feels are going to be soft, hard, or firm. And remember, hard should be when we expect to experience it, like elbow extension. Your outline also talks about the leg length measurements. So we measure leg length from your ASIS to the medial malleolus as a way to quantify leg length discrepancy. Remember that we can have functional leg length discrepancies, which are correctable, and then we have non-functional, which are our permanent leg length discrepancies. And the amount to which we can address the compensations related to that discrepancy relate to how correctable it is. We also want to know that gait deviations are going to be present as a result of those things. And so, is the gait deviation happening on the longer leg or the shorter leg? Is it happening during swing phase or during stance phase? And what do we expect to see? What makes sense? If you've got a longer leg on one side, when are you going to need to swing it out to the side? What are you going to need to do on the shorter leg while you stand on that leg? And so, think about those things, mimic them out for yourself. If you have an exam questions where you see measured asymmetries, think about how those are going to relate to pain and posture as well. Because, gait, obviously, we're talking about that being affected, but pain and posture are going to be impacted by asymmetries in the body as well. Touching back on end feels, remember that those describe the quality of resistance that you feel as you move the joint to the end of its available range. And so if we don't take a joint to the end of its range, we won't know end feel. So be careful about that information as well. Normal end feels, again, are going to be our firm capsular, such as shoulder external rotation or shoulder flexion. Our soft tissue approximation, like elbow flexion or hip flexion or knee flexion. And then our hard bony, like elbow extension. Our abnormal end feels are going to include things like empty, where that's pain limited. So the patient's telling you to stop because of pain before you feel any kind of restriction related to the tissue. A springy block, where it kind of does that rebound, and that's going to indicate something like a meniscal tear. A hard stop, where bones should not be limiting the motion, and that again is going to typically be a joint obstruction. Joint play and accessory motion testing is typically more in the PT's domain, but the PTA is still going to have to note whether a joint seems to move more or less than it's supposed to. So whether it's excessively lax or unusually stiff, we need to be able to determine that working with the patient in order to communicate it to the PT. For the exam, what's important to pay attention to is just whether or not you're getting information that tells you if the joint is moving more than it's supposed to. We probably need to build stability and protect it. If it's moving less than it's supposed to, we probably need to do some stretching range of motion activities. If we read about like a springy block with knee extension after a twisting injury, we're going to relate that to a meniscus, because we're going to think about the twisting inside the joint and how that can cause meniscal tear, and that flipping up of the meniscus can cause that springy block. I'm sure somebody has had a meniscal tear and felt that springy block, because I myself have. But just paying attention to how we can connect joint derangements to our abnormal end feels to be able to identify, hey, something isn't right here. Hopefully this is just a refresher review, but manual muscle testing goes from 0 to 5. 0 is there's no visible or palpable contraction. 1 is there's a trace contraction, but there's no movement. So you can palpate the contraction, but they don't get any movement of the extremity. 2 is full range of motion in a gravity eliminated position. 3 is full range of motion in a gravity resisted position. 4 is full range of motion against gravity with moderate resistance, and 5 is full range of motion against gravity with maximal resistance. If they're positioned in a gravity eliminated position, they are automatically less than a 3 out of 5. And so if it is a picture question and you see that the test is being performed entirely in a gravity eliminated position, they have to be less than a 3 out of 5. And so then we look, did they have movement? If they did, we're probably going to give them a 2. If they didn't have movement, but there's a palpable or visible contraction, we'll give them a 1. If they didn't have movement and we didn't see anything contract, it'll be a 0. You should not have to worry about pluses and minuses for the NPTE. Many questions are going to describe their strength, not necessarily give you a number. So they'll tell you what the patient can do rather than giving you the manual muscle testing grade. And so your task is to then figure out what manual muscle testing grade should correlate with that function. So whether or not they're moving against gravity. If they're moving against gravity and their range of motion is limited, they aren't achieving a full 3 out of 5 if it's strength related, especially if we're told in any other part of the question that they have normal passive range of motion. If gravity is not involved in the position, that can also influence. If they're lifting something, whether it's they're moving just the extremity or there is some kind of weight, whether that's holding something in the hand because it's functional or they've got heavy steel-toed boots as part of their work description. But listening to the functional understanding of what direction the movement's happening and whether or not they would score at least a 3 out of 5 is important to be able to give yourself a good estimate of these values. Manual muscle test grades are going to translate directly into our functional abilities, and so that's why they'll do things that way. So just to kind of reference for you guys, a 3 out of 5 muscle can move through the full range against gravity, but it can't handle extra resistance. So this might be enough for level ground walking, but not for climbing stairs or hills. Or a patient can reach their arm up overhead if it's empty, but they can't put a cup in the cupboard. Thinking about that functional application. A 4 out of 5 muscle can handle some moderate resistance, and so that can correspond to things like being able to climb stairs or performing a little bit more demanding tasks without demonstrating any kind of knee buckling. A 2 out of 5 muscle can't complete full range of motion against gravity, so that patient might require a gravity eliminated exercises or an assistive device to compensate in order to maintain functional independence and safety. So when we're looking at exam questions, we want to connect the described manual muscle test grade to what the patient realistically can or can't do safely. Also, try to remember to consider pain and endurance and not just their peak strength. Patient being able to demonstrate a 5 out of 5 manual muscle test, but that's their 1 rep max, isn't going to be able to then complete a functional activity after that. And so they might not technically be a 4 or 5 out of 5, and they still fatigue or experience pain quickly, or they might technically be a 4 or 5 out of 5, but they're not going to maintain that 4 or 5 out of 5 strength because of the fatigue that they can experience. Posture and gait are going to be considered data collection because they give you a ton of information quickly. In standing posture, we want to look for things like forward head, rounded shoulders, increased or decreased kyphosis, increased or decreased lordosis, a scoliosis, or a pelvic tilt. Remember that our plumb line should run through the external auditory meatus, the acromion process, the greater trochanter, and then just posterior to the patella but slightly anterior to the axis of the knee joint and slightly anterior to the lateral malleolus. If we see posture outside of alignment with that or described as any of those other things listed here on the slide, we want to determine what's normal, what's abnormal, and how do we correct it if it's abnormal. And so remember, we're going to stretch the short side and strengthen the long side. But being able to use data collection, this is how it kind of parlays into interventions, and those two sections can overlap a little bit. For gait, we want to identify common musculoskeletal deviations. So like an antalgic gait is going to be a painful gait that has a shortened stance time on the painful side. Trendelenburg gait has the contralateral hip drop due to weak hip abductors, so glute med. So remember, this one seems to be getting confused a little bit, but if I have my left hip dropping when I walk, that's because of my right glute med is weak, because my right glute med is the one that's controlling the level pelvis during the right stance phase, and it's dropping during my left swing phase, which happens at the same time as my right stance phase. If that was confusing, text me, let's talk about it, we'll make some videos. Circumduction and vaulting are often going to suggest an effectively longer limb or limited knee or hip flexion. And so circumduction is going to happen during the swing phase on the longer leg. Vaulting is going to happen during the stance phase on the shorter leg. But either way, the goal is to help create greater clearance for the longer leg. Anthropometric data like leg length measurements and range of motion and strength findings should help you explain the gait and posture deviations that they might be explaining. So a test item, a STEM, might describe a specific gait pattern and use another piece of objective data that supports the underlying impairment to then ask you to select the best intervention. And those are going to be more of your level 3s to synthesize that information, but it's still capturing your data collection knowledge. Can also look at data collection as a piece of functional measures that can combine information of range of motion, strength, balance, and coordination together in one functional measure. So things like the timed up and go or the tug, that's going to measure our basic mobility and fall risk. A typical cutoff for that is going to be to greater than 12 to 15 seconds, suggesting impaired mobility and increased fall risk. Our single leg stance time gives information about hip strength and balance. So very short hold times are going to be correlated with higher fall risk. The longer a patient can hold, the better balance they demonstrate and the lower fall risk that they have. Sit to stand tests like the 5-time sit to stand or the 30-second stand test are going to help determine a level of information about patient's leg strength, their balance, and their endurance. So longer times needed to complete a 5-time sit to stand or a need for upper extremity support indicates a decreased functional lower extremity strength. Our cutoff for there is, I want to say 12 seconds for the 5-time sit to stand, but somebody can fact check me on that because I don't have it in front of me right this second. Your study guide also talks about patient-reported outcome measures for musculoskeletal data, and so that's going to include things like the Oswestry Disability Index, or the ODI, the Neck Disability Index, or the NDI, the DASH, the LEFS, or the Lower Extremity Functional Scale. And those are going to have a little bit broader application, or broader range of numbers, I guess is a better way to phrase that. And so you don't necessarily need to know the exact cutoffs for each of those patient-reported outcome measures, but it is important to know that higher disability scores are going to reflect more limitation, and decreasing scores indicate more improvement. So paying attention to each scale tells you level of function. Like a higher ODI scale is a higher level of disability. So we actually want our patients to score lower on the ODI. So let's check out another question. A patient can move the shoulder partially through the available range against gravity, but cannot achieve full range in that position. In a gravity-eliminated position, the patient can move through full range. What is the most appropriate manual muscle testing grade? Now, I will say I use this one as a little bit of a trick, but the answer is B, because the patient has some motion against gravity in a gravity-resisted position. It give them a 2+. However, remember I said that you shouldn't get caught up with pluses and minuses on the MPTE. It should be clearer cut than that, because there could be a lot of argument made, and they don't like to have that much gray area on the test. Moving on to neuromuscular. So neuromuscular data collection is going to cover sensation, reflexes, tone, coordination, balance, and gait patterns. Our neurologic gait patterns, not our musculoskeletal gait patterns. So your study guide has highlights on things like pathologic reflexes for Babinski and Hoffman, and different types of involuntary movements, cranial nerve screening, and neural tension tests that I'm not going to really cover in here. But your job with those is to recognize the patterns. If we have hyperactive reflexes and spasticity, we're looking at upper motor neuron lesions. Absent reflexes and flaccidity are going to point towards lower motor neurons. Remember that paralysis is the only one that we'll see with both upper and lower motor neuron injuries. Peripheral nerve involvement can be involved with absent reflexes and flaccidity as well, so just paying attention to where the injury has actually occurred. When we combine this information with other information like coordination and balance testing or our gait observations. We have a functional picture of how the nervous system injury is affecting the patient, and that can lead to synthesis questions like the intervention level determination from there. So we want to keep pattern recognition in mind as we review each of our components of this. So sensation testing can include superficial, deep, and cortical components. Our superficial sensation is going to include light touch and sharp versus dull pain. Deep sensation is going to be our joint position sense, so our proprioception and our kinesthesia. And our cortical discriminatory tests like stereognosis, graphesthesia, and two-point discrimination and barognosis are going to be our cortical level. For dermatomes, know your landmarks that we went over in class, but your big ones like the thumb for C6, middle finger for C7, little finger for C8, your medial malleolus for L4, great toe for L5, Achilles for S1. Just remember where we would test those in class. Again, there's a reason we did a dance, but knowing your dermatomes is going to be an important thing for neuromuscular data collection. If a question describes absent light touch over an area and then combines that with other data about muscular involvement or muscular weakness, we want to be able to determine the level of the injury. And so knowing your dermatomes for sensation can be important to correctly identify the level of injury. And always compare side to side if that information is available in the question, especially if it's a scenario type question. Our DTRs, or our deep tendon reflexes, that we can commonly see on the MPTE are going to include the biceps reflex for C5, C6, brachioradialis for C6, our triceps for C7. Patellar reflex is going to be L4. Achilles reflex is going to be for S1. Our reflexes are going to be graded from 0 to 4+. So 0 is going to be an absent reflex, 1+ is diminished, 2+ is normal, 3+ is a brisk or quick reflex, and 4+ is very brisk, often with clonus, and so that's where we'll see that repetitive muscle activation. Hyperactive reflexes are going to point towards upper motor neuron involvement, and so that's going to be our 3+ and 4+, while diminished or absent reflexes are going to suggest our lower motor neuron and peripheral involvement, and so that's going to be our 0s and our 1+. Your study guide also talks about pathologic reflexes, like Babinski sign. So a positive Babinski in a baby is normal up until the age of integration, but a positive Babinski sign in an adult, remember Babinski is going to be where you stroke the lateral foot and you see extension of the great toe and fanning of the other toes. That's going to be an upper motor neuron sign, those pathological reflexes. And a positive Hoffman sign, so that's flicking the distal middle finger, produces thumb and index flexion. That's another upper motor sign for cervical pathology. On exam questions, you want to make sure that you're looking to match patterns to diagnoses, so that way you can best understand the information and how it's being presented. Because you might find yourself at risk of adding in details or asking the well, what if this question if you don't look at the data presented in the context of the diagnosis. Muscle tone refers to the resistance to passive stretch when a muscle is at rest. You should be comfortable being able to describe flaccidity, hypotonia, normal tone, and hypertonia, and having those things described to you. Spasticity is a velocity-dependent increase in tone associated with upper motor neuron lesions, whereas rigidity is more constant resistance and doesn't have a velocity dependence, so it doesn't matter what speed you move it in. And rigidity is more common in things like Parkinson's. The modified Ashworth scale helps us to score tone, and it ranges from 0 to 4. So 0 is no increase in tone. 1 is a slight increase in tone with a catch and release or minimal resistance at the end of range. 1+ is a catch followed by minimal resistance through less than half of the range. 2 is a more marked increase in tone, but the limb is still easily moved. 3 is a considerable increase in tone with difficulty moving the limb. And 4 is the limb is rigid in flexion or extension, so it holds one position. When exam questions describe tone, you want to be able to link those descriptions to whether they're upper motor neuron or lower motor neuron patterns, and that then to the functional implications like safety with things like transfers and gait. Coordination, coordination testing. So looking at coordination tests such as finger to nose, heel to shin, and rapid alternating movements are going to assess the cerebellum's role in smooth, accurate movement. Dysmetria is a term that you might come across that describes overshooting or undershooting a target, so whether that's stepping or reaching for the target, but not being able to judge the correct distance. And dysdiadokinesia, which remember is that difficulty with rapid alternating movements, are classic cerebellar signs that might be described. So if you see dysmetria, ataxia, or dysdiadokinesia described in a stem of a question, we're pointing towards cerebellar involvement. Balance tests that you should recognize are going to include the Berg Balance Score, where scores less than 45 out of 56 are going to indicate increased fall risk. The Tonetti is going to, again, be another balance assessment where lower scores indicate higher risk. Our single leg stance, remember the shorter duration of time they're able to maintain a single leg stance, the higher fall risk they are. And then the timed up and go with our 12-second cutoff. The Romberg test, which is not on here but worth mentioning, remember, is going to help us be able to differentiate between sensory or vestibular issues from purely cerebellar issues. So if a patient has loss of balance when the eyes are closed but they don't have loss of balance with the eyes open, then that's going to help us indicate more towards the sensory from vision impairments than it is cerebellar vestibular deficits. Neurologic gait patterns different from our musculoskeletal gait patterns. These are very testable and often very vividly described in exam questions, and so being familiar with them can help you make determinations for the question to answer it correctly. So a hemiplegic gait after stroke is typically going to involve circumduction of the paretic leg and a reduced stance time on the affected side, and a flexed elbow and adducted shoulder on the involved arm. Parkinson's gait is characterized by a shuffling pattern with a narrow base of support, decreased arm swing, sometimes festination where the steps become smaller and faster, and we'll also typically see a forward flexed trunk posture in Parkinson gait. Ataxic gait or cerebellar gait from cerebellar dysfunction shows a wide base with unsteady steps and variable stride length. Sensory ataxia presents with a stomping gait that worsens when there isn't visual input and often has a positive Romberg. Other patterns that they might talk about can be steppage gait with foot drop. Can be due to many neurologic factors, whether that's going to be neuropathies or CVA or TBI or even lower spinal cord injuries. We can also see scissoring gait described for spastic cerebral palsy, and excuse me, like things like toe walking due to spastic plantar flexors, whether that's in the cerebral palsy population or the cerebrovascular accident or traumatic brain injury, any of those populations where we can see that kind of presentation. Either way, the point is that when the exam is describing gait, especially with detail, we want to use that as another piece of objective information to guide how you are understanding the question and get as much information from that gait description as possible. So the better you can understand the gait, visualize the gait, and interpret the gait, the better off you'll be for level 1, 2, and 3 questions. Checking out our question, a PTA tests the patellar tendon reflex of a patient post-stroke and documents it as a 4+. Which of the following best describes this finding? A. Normal reflex response at L4. B. Diminished reflex consistent with lower motor neuron lesion. C. Hyperactive reflex with possible clonus indicating upper motor neuron involvement. D. Absent reflex due to peripheral neuropathy. pause here if you are not prepared for me to move on to the answer. So the correct answer here is going to be C. We're seeing a hyperactive reflex with possible clonus indicating an upper motor neuron involvement. So 2 plus would be normal, right? And this patient was scored as a 4. And so 0 or 1 plus is a lower motor neuron injury because those are going to be hyporeflexive. 3 plus and 4 plus are going to be our hyperreflexive. And so we're looking at upper motor neuron lesions with hyperactive reflexes. When you see a reflex grade of 4 plus in an exam question, think automatically for upper motor neuron patterns. If you see a 0 or 1, you're going to think lower motor neuron or peripheral nerve involvement. The quicker you can make that association, you can eliminate distractions and get rid of those this one might be right, but it's not the best answer situations. Moving on to integumentary. So integumentary data collection starts with simple skin inspection, and that's more than just saying I'm checking the skin during a practical. But it also progresses to detailed wound assessment and pressure injury staging. So the study guide that I gave you guys points to scar assessment to look at, protective sensations, burn classifications, and risk assessment tools like the Braden scale. Take a look through those things, but again, I don't want to make this forever long, so I can only include so much. Integumentary only takes up a small portion of the exam compared to the big three, but they're typically predictable, and so if you can understand this information, you should be okay. You're usually asked to recognize a pressure injury and be able to stage it, maybe identify the signs of infection present in a wound or skin, respond appropriately, whether that's with the right dressing or measurement style for wound characteristics. So pay attention to the different classifications there for these highlights because, again, there's only a small sample of integumentary questions, and so we can kind of focus our attentions. So we would start any integumentary assessment looking at the overall skin condition. So we'll note color, whether it's pink, pale, cyanotic, red, or bruised. Check temperature to see if there is warmth or coolness. Warmth can suggest inflammation or infection, and coolness can signal poor blood flow or perfusion. Look for edema, rashes, scars, and any areas of breakdown. Classic localized signs of infection are going to include erythema, warmth, increased pain, swelling, and purulent drainage. So remember, that's pus. Systemic signs of infection, though, those are going to include fever, malaise, or elevated white blood cell counts. If that information is provided, that's going to be more likely in a scenario question, but it might be in the stem of a question. Also consider scar appearance and mobility if that's present. Hypertrophic and keloid scars may be raised, and adhesions can limit motions, and so we want to remember that integumentary assessment can factor into our musculoskeletal outcomes as well. So if a stem describes increasing redness, warmth, and purulent drainage, you should automatically think infection. If they describe post-surgical incision with beading over the incision site, that's going to tell us more of a keloid scar, and that can be contributing to deficits. And so looking at the overall skin condition, how they're describing each of these factors. For wound assessment, we want to look to describe the location, size, depth, and tissue type. So they might ask you to make judgments about how you would perform those assessments and selecting the most appropriate answer, or provide that information for you to utilize to make, again, your synthesis level questions. So if we're measuring length and width, we'll probably use our bullseye. Depth is often used in centimeters with a sterile cotton swab, so make sure that that would be a detail you're looking for in an answer or the stem. We want to describe or look for descriptions of the wound tissue types and understand what those descriptions mean for how the wound is healing. So granulation is going to be our healthy red tissue, slough, which is going to be yellow or tan and stringy, and eschar, which is black, brown, or hard necrotic tissue. Noting the amount and type of drainage is going to typically use terms like none, minimal, moderate, heavy, but also the type and understanding what that means. So our serous is going to be our cleared, our sanguinous is going to be bloody, our serosanguinous is kind of that clear bloody, and our purulent is pussy. We want to be able to inspect wound edges as needed for data collection purposes, but looking for that information if we have a wound specific question to give us an idea of how the wound is healing. Maceration is going to be typically from too much moisture, and so we've got that wrinkling of the skin. Think about when you get pruny. Induration or rolled edges are also going to be signs of abnormal healing that we would want to notify the PT over. Over time of healing, they might also need to be able to identify in a question whether a wound is improving in size and symptoms, and type of tissue present. So we want to have increasing granulation tissue to suggest healing over time versus increasing slough or eschar is going to be an indication that we need to seek different medical intervention. And then looking for signs in the question like about the size, odor, and again drainage is going to help us rule in or out infection for the purposes of answering the question and whether or not that's a safety concern that needs to be monitored. Pressure injury staging is going to be very important to know. Remember that can be a key trigger point for questions. So stage 1 is non-blanchable erythema on intact skin. Stage 2 is partial thickness skin loss involving the epidermis and possibly the dermis. These will often appear as an abrasion, a blister, or a shallow crater without visible fat. Stage 3 is where we might have visible fat, so this is going to be our full thickness skin loss extending into the subcutaneous tissue. You may see fat, but you're not going to see bone, tendon, or muscle because that's in stage 4. Stage 4 is our full thickness skin and tissue loss with exposed bone. So stage 3 and stage 4 full thickness, it's just what extent of the tissue that we invade down into. Stage 4 we see exposed bone, tendon, or muscle. An unstageable injury is one where the base is covered by slough or eschar, and so you can't determine the true depth. A deep tissue injury, so one where we might not see superficial wound, but we can tell there is deep tissue injury, is going to present as a persistent, non-blanchable, deep red, maroon, or purple discoloration. So if you see something described as a spot on a person's body that is non-blanchable in one of those colors, especially if it is over a bony prominence, especially if they have had a long period of immobility, we're going to think deep tissue injuries. And how do we address that? Positioning. So when answering questions for integumentary and especially staging, we want to think about attaching keywords to each stage to limit the impact of distractors. So simplify this as best you can, so that way, oh yeah, that's that word, okay, I know, that's stage 2, I got it. Blister, stage 2, I'm on it. Let's do a quick knowledge check. A patient presents with a heel ulcer that exposes subcutaneous fat, but no bone or tendon. The wound bed is mostly granulation tissue with some slough, and there is moderate serous drainage. Which pressure injury stage is most appropriate to document? A, stage 1, B, stage 2, C, stage 3, D, stage 4. Pause now if you are not ready for the answer. And the answer is C, stage 3. So stage 3 is going to involve that full thickness skin loss where there might be visible fat, but either way it's going into the subcutaneous. And so that's where we saw in this one, the wound bed was primarily granulation tissue, and so we can definitely say it's stageable. We can see a depth and determine an absolute depth, and we can see that there's no exposed bone, tendon, or muscle, so we haven't gotten all the way to a stage 4. So again, key tip, look for words like fat visible or bone exposed to say the difference between stage 3 and stage 4, so that way those keywords help make it easy for you to rule out the other answers. Lymphatic and edema data collection is going to be about quantifying swelling and recognizing patterns that suggest lymphedema versus other causes of edema. and helping to determine the appropriate intervention based off of that. And so, again, that's that synthesis, bringing it up the next levels of questions. Sometimes it'll talk about measuring girth at standardized landmarks, or a set number of centimeters above or below a specific bony landmark or joint. And so looking at consistency in measurement between data that you're provided to help determine the answer can be important. We also want to look at whether or not we're provided with information that compares the involved and uninvolved limbs, so that way you can make best use of all of the information to select the best answer. We might also talk about figure 8 measurements at the ankle or the wrist, but primarily the ankle. And then the pitting edema scale from 1 plus to 4 plus, we touched on that earlier. But remember, it describes the depth and rebound time of indentation. So our 1 plus is 2 millimeters, barely detectable with an immediate rebound. 2 plus, 4 millimeters, with taking a few seconds to rebound. A 3 plus goes 6 millimeters and takes 10 to 12 seconds to rebound. And a 4 plus is going to be 8 millimeters, which is a very deep pit and takes greater than 20 seconds to rebound. Severe chronic edema can progress to firm fibrotic tissue, and it can even then progress to weeping where fluid leaks through the skin. And so understanding the staging and levels can be important. It's important to be able to distinguish lymphedema from other types of edema. So lymphedema is often chronic, and it can be unilateral, especially after lymph node removal or radiation from cancer treatment. And so those are key indicators that would help us say, okay, we've got unilateral swelling, or we've got swelling after resection, or long-term chronic, duration is going to give us some indicators towards lymphedema. Over time with lymphedema, the tissue typically becomes firm and fibrotic, so we progress through the stages of pitting edema into a more firm and fibrotic edema, and that's where we'll see skin changes. A classic sign that they can reference on the test, and that's important to be familiar with by name, is a Stemmer sign, which is the inability to pinch the skin at the base of the second toe or finger because of the rigidity of the skin. And so any information in the question stem that references Stemmer sign is going to help point you towards lymphedema. Edema from heart failure or venous insufficiency is more often going to be bilateral. It's typically pitting and associated with other signs like varicose veins or discolorations from the staining of blood pooling. Palpation of lymph nodes can also provide data, and so you might look for information in the stem of the question that tells you the lymph nodes are tender, which is going to point us towards infection and identifying infection and appropriate referral. Hard, immobile lymph nodes are going to suggest more serious pathologies like cancer, and so again, medical referral, but what level of urgency, because we might have two answers that talk about medical referral, and determining the right one based off of lymph node presentation might be an important factor. You're not going to be required to diagnose anything from this, but being able to know how to follow the correct chain of command can be important. So using that information, take a quick knowledge check. A PTA notes that a patient with chronic unilateral lower leg swelling has firm, non-pitting edema and a positive Stemmer sign at the base of the second toe. Which interpretation is most appropriate? A. Findings are most consistent with lymphedema. B. Findings confirm acute deep vein thrombosis. C. Findings indicate simple dependent edema from sitting. D. Findings rule out lymphatic involvement. Pause now if you don't know the answer and need more time to think. So the answer to this one is A. It's going to be lymphedema, and again, you're not going to be asked in the NPTE to create or to diagnose like a question like this is asking you to do. However, creating these quickly may have not given me the best frame of reference in writing the practice questions, but either way, you're able to identify those important key terms like chronic and unilateral, and even the positive Stemmer sign, and the non-pitting moving into because of the chronic nature of lymphedema and the progression through the stages, that firm appearance helps us point towards it being lymphedema. And so how we treat that is going to be different than how we would treat edema from, say, congestive heart failure, and what changes in limb girth are going to be relevant. With lymphedema is going to be less life-threatening to have a significant change in limb girth than with limb swelling from congestive heart failure, and so we need to be able to refer appropriately to the doctor, or just notify the PT, or provide with the appropriate compression garment because it's lymphedema flare up, And so understanding the type of edema is important for, again, synthesis level questions. These next couple slides, I'm going to give you a couple of scenarios. There are no correct answers that I am going to provide you. These are just scenarios with questions to help make you think and just get your wheels turning. So this one, we're looking at a 65-year-old status post, right total knee arthroplasty, post-op day number 2. Current findings: knee flexion, active range of motion 0 to 70 degrees, quadriceps strength 3- out of 5 with moderate edema. Vitals with gait include heart rate 92 beats per minute, blood pressure 138/82, O2 sat 95% on room air. Knowing this and thinking about this patient, visualizing them, thinking about all of the factors at play here, which data should the PTA prioritize collecting at the next visit? Take some time to think about it. How would it impact what information you need to know and study for this MPTE? Things like that. Next scenario, COPD and gait. So a patient with moderate COPD is completing hallway gait training. Their baseline respiratory rate was 18 breaths per minute. Their O2 sat was 95% on 2 liters of oxygen with mild dyspnea at rest. Mid-walk, their respiratory rate was 28 with an SpO2 of 90%, reporting moderate dyspnea and RPE of 13. What is the most appropriate PTA action in this situation? What would you do? How would you treat this patient? Stroke and balance. Patient 3 weeks post left CVA with right hemiparesis. Findings: a modified Ashworth of 2 in the right elbow flexors and a patellar reflex of 3+ on the right. Berg balance score of 38 out of 56, requires contact guard for gait with a quad cane. What is the best interpretation of these combined data? What do you know about this patient and their needs for therapy, functional demands, anything that you can connect based off of the data that's provided here? So high yield focus areas to review, just kind of a checklist to make sure that you focused on this information. If nothing else for data collection, you have gone over this to help support you for licensure. So normal vital sign ranges and abnormal exercise responses are common range of motion values in manual muscle testing grading with functional meaning. Our key dermatomes, reflex grading, and tone interpretation, so using that modified Ashworth scale. Pressure injury staging and basic wound infection signs, and edema grading and basic lymphedema versus general edema patterns, so that you can recognize between the two. I covered all of them in here, and so if you review this a couple of times and you go through the study guide that I provided you, you should be good. And one last reminder for some test taking tips: go ahead and underline key numbers and descriptors in the stem. If it seems important, not all of your questions, let me rephrase because underline is probably not the right word. Go ahead and highlight. So you've got a cursor on your keyboard, right? So we can't underline it because it's not a paper test, but we can highlight it with our mouse, and we can put something under it, and we can mark it in some way on the computer just by bringing our attention to it. Because that's going to say, okay, there's data collection in this question, and I don't want to miss it. When you look at that data, then you're going to say, is it clearly normal, clearly abnormal, or is it borderline? We'll eliminate answers that are outside the PTA scope and that ignore safety red flags, because why are they going to test you on something that you can't do? and choose the least drastic but also safe option that addresses the problem. So remember, we don't want to escalate and elevate higher than it needs to go. We want to choose the least drastic but still safe option. Good luck, everybody.